All right, so clinical MRS, I'm going to start off with this case, and this is different to the case that we saw earlier this morning. This is a patient that came in with headaches and had this ring-enhancing kind of lesion on a CT. Here's a flare, here's an abnormal signal on the T2, and it looks like it's crossing the genu of the corpus callosum and causing some mass effect and expansion of the callosum. Post-SCAD, it's certainly enhancing a lot, very heterogeneously, and not a lot of diffusion restriction on the diffusion and the ADC map. Okay, so who thinks this could be a tumor? Who thinks this could be a non-tumor? Okay, so we're split again in the audience, and this is the kind of case where I think MRS and perfusion can be useful to help us with this differentiation. So let's look at the MRS then. So here's a voxel within normal brain, and you see the normal NAA, normal choline, and normal creatine. And here's a voxel from the abnormal lesion. And I've magnified this to show that there are no metabolites here. There is some lactate within the lesion, but generally when you look at the entire lesion itself, there is really no evidence of metabolites. So let's go back and ask the same question. Who thinks this is a tumor now? Okay, who thinks this is a non-tumor? All right, so I think it's clearly evident from the audience that when you look at spectroscopy now, I think it's very important to look at the normal side and compare it with the abnormal side. And what we're learning more and more now, if you have a decrease in overall metabolites, such as this, you end up with a non-tumoral entity. So this is end up to be necrotizing encephalitis on a biopsy. If this was a high-grade glial tumor, an infiltrating tumor, the choline levels in the peritumoral area would be markedly elevated. And certainly in the area of abnormal T2 signal, the choline will be elevated. So this is one way where we can differentiate these two pathologies. So what we're going to try and cover today to try and show you ultimately in a case-based like review at the end is what technique are we going to use for MRS, what echo time and what sequences are we going to use, whether it's single voxel, 2D or 3D CSI. What are some of the regional and age-related changes that you see? Some pitfalls when you're acquiring spectra, how to post-process spectra, which is really very minimal these days, how we report spectra, and then finally show you some clinical cases, non-tumoral and then some tumoral cases at the end. This is the nomenclature, and this is all in the CD, so I won't go through that, but there are a lot of abbreviations now, and a lot of them stand for the same thing. So you'll see multivoxel spectroscopy, MVS, is the same as CSI, chemical shift imaging, which is the same as MRSI, MR Spectroscopic imaging, which is the same as spectroscopic imaging and 2D CSI. And now this is supposed to be 3D, so three-dimensional CSI as well. So what technique are we going to use? The first thing you want to do is ask yourself, what are we doing spectroscopy for? Are we doing it for localizing the extent of a lesion? Are we doing it to make a diagnosis? Most of the time, we would do spectroscopy in the setting of a focal or tumoral abnormality. So in the setting of a tumor, we generally speaking would do multivoxel CSI at an echo time of 144 or 135 milliseconds to try and delineate the lesion and the extent of it. If you had very diffuse disease, so for example, Alzheimer's disease or degenerative disease that was involving the entire brain, then you can get away with running single voxel spectroscopy because presumably the whole brain is going to be abnormal in that setting. There are two major pulse sequences that you would use for MRS. One is called STEAM, Stimulated Echo Acquisition Mode. This is essentially a gradient echo sequence, so the signal from that is not as high as if you were to run a PRESS sequence, and PRESS stands for Point Resolve Spectroscopy. This is a spin echo sequence, and this is tends to generate more signal to noise, and you can get spectra at very short echo and very long echo time using a PRESS sequence. So this is what we're tending to use now in the clinical setting. Just to show you the difference, these are spectra obtained at longer echo time with a spin echo PRESS sequence versus a gradient echo STEAM sequence, and you can see that the signal to noise from a STEAM sequence is about half that of a PRESS. So you're getting much more signal to noise using a PRESS sequence. So how do we look at spectra? If we were to do longer echo time MRS, you can see that the major metabolites we'd be seeing are NAA, choline, and creatine. And this is where these metabolites are located. NAA here at 2.02 ppm, creatine at 3 ppm, and choline at 3.2 ppm. There is a second creatine peak here at 3.9 ppm. How do you look at abnormal spectra then? If you look at the horizontal scale, you'll see that the units here are in parts per million. And you generally would read the spectrum from right to left. So the horizontal axis is really just showing you the location of each of the metabolites. So each of the metabolites will resonate at a different frequency shift depending on how many methyl components there are in the metabolite. And this will tell you the location of the metabolite in relation to the other metabolites. So all the horizontal axis is really showing you is the location of the metabolite. The vertical axis, and some of the manufacturers may have no units whatsoever on the vertical axis. On the Siemens scanners, you will see a number here, but there is no unit. And I tend to use the numbers sometimes to demonstrate ratios or to calculate ratios, but remembering there's actually no unit on the vertical axis. So how do we then interpret the spectrum? Generally, we would look at NAA, choline, and creatine. This is a normal looking spectrum. This is what you would expect to see. If there was an abnormality, and we'll go through what some of the abnormalities are that can cause this, generally speaking, you will get a reduction in the NAA and an increase in the choline. And you'll get a reversal of this metabolite angle, so-called, and the angle would tend to be reversed like this, and this is a tumor angle or certainly a normal spectrum that you would see. The reason why you would see myo-inositol and some of the other metabolites at a shorter echo time is because these metabolites, such as myo-inositol and glutamate, have a very rapid T2 decay. So at about 35, 40, 50 milliseconds, you'll tend to lose most of these metabolites when you look at the echo time. So on the horizontal axis here, we have the echo time, the TE, and the vertical scale is really the concentration. If we were to do longer echo time, so 135, 140 milliseconds here, you would see that you'll still see some NAA and choline, but you won't see any more myo-inositol or glutamate because these have decayed very rapidly. So that's a reason why a short echo time spectrum like this looks very different to a longer time or an intermediate or long echo spectrum. So not only do you see NAA, choline, and creatine, but as well as that, you'll see metabolites like glutamate at 2.05 to 2.5, these kind of triplet peaks here, as well as myo-inositol at 3.56 ppm, which have a very short T2 decay. So these are metabolites that you would only see using a short echo time. Just to show you the differences then, when you change it, the spectrum actually changes when you change the echo time. So short echo time, see a couple of these other metabolites, and as you increase the echo time going across and down this table of spectra, you can see that you tend to lose a lot of the other metabolites, and when you go to very long echo time, all you're really left with is NAA, choline, and creatine. This is some spectra showing you the effect of echo time on the same voxel. So I've put a single voxel in this recurrent tumor here and obtained spectra at 30 milliseconds, 144 milliseconds, and 277 milliseconds. This shows you the effect of echo time on pathology. So if you look at this first spectrum, within the tumor, you can see that there's increase in choline, there is decrease in NAA, there is this lactate lipid peak. So the lactate at short echo time is above the baseline, and it's a doublet, and it becomes below the baseline at intermediate echo time, 144 milliseconds, and then it's above the baseline again at 270 milliseconds. If you were to look at the second thing, there are a couple of take-home messages here. The second thing is that if you look at short echo time, you may be misled to think that there may be some NAA here within the spectrum, but in fact, as you go to longer echo time, there's no NAA at all. So the pitfall is that at short echo time, you may be misled because the GLX peaks gives you the impression that there may be some NAA within the spectrum, whereas as you go to long echo time, there is really no NAA at all. Lastly, almost lastly, you'll see some myo-inositol here, which we won't see at longer echo time. And then lastly, you can see that if you put a voxel within the CSF on the lower voxel, you really shouldn't see any metabolites at all. So what technique do we like to use? Generally speaking, at our institution, we would use a 2D CSI multivoxel technique. So here's an 8x8 spectrum or spectral map. And we like this because you can get not only data from within a lesion, if there was a lesion here, but as well as that, some contralateral voxels as a control. If you have it on your machine, you can also do three-dimensional CSI. So not only will you have an 8x8 matrix, but you'll have an extra 4 slices or 6 slices. So you have a three-dimensional MRS set. Certainly, there's a lot of data here, but I think sometimes the more data you have, the more useful the interpretation will become. If you just had single voxel and you had something like a diffuse disease like Alzheimer's disease, if you were to put the voxel in the posterior cingulate gyrus in the gray matter or in the white matter here in the parietal white matter, you should still see the same abnormality, but keeping in mind that you want to keep it away from fat, scalp, bone, and CSF. The advantages really of single voxel is that it's freely available now, and it's very flexible and very accurate in voxel location. But I think that it's still really not as advantageous as multivoxel spectroscopy, where you really have a lot of spectra and a lot of voxels for comparison. I think this is useful when you're trying to compare from side to side, giving you some spatial resolution. 3D spectroscopy, you can see now that we can do in the posterior fossa, where historically it's been very difficult to obtain good quality spectra because of the inhomogeneity within the posterior fossa. But I think now with the quality of the software and hardware, we're able to obtain very nice quality with a 3D data set in the posterior fossa. So you can go ahead and try that. As we do more and more MRS, we're learning now that there is certainly quite a lot of variation between different regions of the brain. As a general rule, there is some decrease in NAA when you go from anteriorly or ventrally to dorsally. NAA is generally higher in the gray matter, in the brainstem, and in the basal ganglia. Similarly, choline levels are generally higher in these structures, probably because of the nuclei that are situated in these structures. Just to show you the regional variation, and this is in the same patient using an echo time of 144 milliseconds, the same voxel size, a single voxel acquisition. If you place the MRS within the gray matter in the posterior cingulate gyrus, you can see this is a fairly normal gray matter looking MRS with a lot of NAA and not so much choline. If you move the voxel into the parietal white matter, you can see that the spectrum changes quite markedly. There is much more choline, and that's probably because there's more exons in the white matter, and these exons have higher myelination levels, so the myelin is packed closely together and the choline level is resultantly a little higher. When you put a voxel within the pons, so this is in the mid-pons area, you can see that the spectrum looks again very different. Maybe a little less NAA, more choline level, and again, maybe because of the cellularity in this location. And then if you move the voxel from the pons to the cerebral hemisphere, you can see again the spectrum changes. So keeping in mind that not only are there changes within different regions of the brain, but if you look at a structure like the corpus callosum, this is where the axons are packed most closely together, and you can see that the choline to creatine level is probably the highest in this normal structure, the splenium of the corpus callosum. And then when you look at MRS within a single structure, and this is MRS of the hippocampus. Some of you may be doing it in the setting of mesial temporal sclerosis, and if you were to do that, you want to keep in mind that the spectra are different depending on whether you're looking at the head of the hippocampus, the body, or the tail of the hippocampus. So you can see that the NAA levels compared to choline and creatine are in fact lower in the head compared with the body and the tail. So keep that in mind, that even within the single structure, you will see some spatial and regional differences. Now this is would look like what would appear to be an abnormal spectrum, but the take-home message here is that you have to know how old the patient is. Okay, so in this spectrum, if this was an adult patient, clearly it would be an abnormal spectrum. If this is a neonate, in fact, it's a normal spectrum. In the first year of age, the neonatal brain will demonstrate very high choline levels from the early lack of myelination in the brain. And over the first year, as the brain is myelinating, you'll start to see a decrease in the choline. And as the brain matures, more neurons are developing, so you get an increase in NAA, maturing, so you see an increase in NAA. So there's a reversal of the choline to creatine and NAA to creatine ratio. So by about a year of age, you'll start seeing some normalization of these metabolites, and certainly by 2, 3, 4 years, you'll see that the child will obtain fairly normal-looking spectra within the brain. This is some work that came from Barbara Holzhauser's group in the Loma Linda part of our country. You can see that in the first week, the choline is much higher than the NAA, starts normalizing by about 9 months, and then certainly by 21 months and by 8 years old, we're starting to see some normal appearing spectra. So there's age-related variation as well, which will also change when you go from adulthood to very elderly patients. So keep that in mind. Here's a child that was scanned, and we had this MRI which showed some volume loss in the brain. There is also some prominence of the ventricles, so we did MRS on this patient. So let's ask the same question. Who thinks this is abnormal? Who thinks this could be normal spectrum? Okay, so a little difficult, and I've felt initially that this was abnormal because the MR certainly looks abnormal. There's some volume loss in this neonatal brain. Shouldn't be seeing so much extraaxial spaces. So initially we weren't really sure, so I sent the case to Bob Zimmerman up in CHOP, and he looked at it and he said, I agree with you that the MRI wasn't normal looking, but in fact this MRS pattern is in keeping with the neonatal brain. So keep that in mind, that this can be normal. So choline is a very important metabolite. It's seen at 3.22 ppm. It has a role in membrane metabolism, but it is elevated, this metabolite, in a number of different settings: tumors, demyelination, ischemia, and inflammation. As well as that, there is some regional and age variation in the metabolites. So once you've decided to do MRS, all you got to do is really obtain some scout images and then determine what echo time and what technique you're going to use. Are you going to use a spin echo, which is what we would tend to recommend, and then whether you're going to use short echo time or long echo time MRS. Then the only other decision you need to make is whether to use single voxel or multivoxel. And again, our recommendation is to use multivoxel if you have it, 2D spectroscopy, 3D if you have it too. That may give you even more information. Then all you need to do is place the voxel, press the button, and the scanners these days will do all of these steps for you. Will shim, do water suppression, and acquire the data in about 3 to 8 minutes. And all you need to do is then interpret the data set. Lactate is an important metabolite. It's seen at 1.33 ppm, as a lot of you are aware, but it's not normally found in normal brain or maybe in the CSF in trace amounts, but it's certainly seen in a lot of pathologies where there's anaerobic metabolism, necrosis, infection, and demyelination. So here's the lactate peak inverted at 1.3 ppm. Lipids are also seen in the setting of very similar pathologies, and important to keep in mind that often you see both lipid and lactate in the same setting. So I just want to show you this case. This is a tumor, and I don't have any normal voxels to show you, but I want to tell you that the choline level in this voxel and this voxel is much higher than in the normal appearing brain. So it was clear that this was a high-grade tumor. As well as that, we were seeing some other metabolites. Here are around 1.3 ppm, so probably some lipid and lactate. So I want to ask you whether you think this is normal or abnormal lipid. Who thinks this is abnormal lipid in the tumor itself? Okay, who thinks this could be normal lipid from somewhere else? Okay, so there is some controversy and some disagreement in the audience. So then we looked at a normal voxel sitting in normal brain, and you see that even within normal brain, we were seeing some lipid and lactate. So we felt that this is a little weird, and we went back and looked at the VOI that's placed, and you see that in the large VOI, the edge of the voxel is actually overlying scalp fat and diploid space fat. So any lipid that is normal within the extracranial brain will leak into the large VOI, and you'll end up seeing lipid within areas that are normal looking as well. The other tip-off, if you look at this spectrum, is this voxel here is immediately behind this voxel here, and you can see that the lipids in the adjacent voxel is out of phase, so below the baseline. The lipid that is in the adjacent voxel below it is above the baseline, so this is in phase. So you can see that lipid that becomes in phase and out of phase on adjacent voxels is due to artificial lipid, not real lipid. Lipid that's infolded from the adjacent extracranial fat. And this is because of this point spread function, which you should probably know about when you come to do multivoxel MRS and spectroscopy. And that's because when you have a voxel that's close to the edge, you'll have lipids that are infolded from the adjacent voxel, and they'll come in, and on the first voxel, it'll be in phase. On the next voxel adjacent to it, it'll be out of phase, below the baseline, and then in phase, and then out of phase. So if you look at adjacent voxels, you'll see this in phase, out of phase phenomenon from artifactual lipids. You can overcome that these days by putting these out of volume fat suppression pulses overlaying the scalp to try and suppress that, so you can then obtain very nice looking spectra from close to the cortex and cortical lesions. Lastly, before we start looking at interpreting spectra, certainly on the Semen scanner, the only thing you really need to do is correct for that phase abnormality, and that can be very simply done in a matter of minutes now. Most of our fellows do that, and once you've corrected for the baseline, this is the task card on the Semen software that allows you to do that, you're ready to then film and then interpret the spectra. If you're not filming, then what we're doing these days is sending the abnormal MRS as well as some normal spectra with an accompanying baseline image, so we know that where the spectrums come from, to the PACS system, and then we can then read it off the PACS. Sometimes there's a question of the effect of gadolinium on MRS, and a lot of people have looked into this now, and really the changes pre and post GAD on different spectra are very minimal. So we do all of our spectroscopy when patients getting GAD post gadolinium, because we don't think that's it really has much effect on the MRS. So now when we come to reporting perfusion and MRS, I think in the technique it's important to mention that we're doing perfusion and MRS. Typically it's multivoxel MRS, and mention the echo time as well, so that we can either reproduce it, or if you're doing it somewhere else, they can know what technique you're using. Describe the conventional MRI findings, and then describe the perfusion findings. Typically would give a value for RCBV if that's elevated of 2.6 or whatever it is. And then the MRS, in the past we used to give these choline to creatine ratios and NAA to creatine ratios, and I think I'm going to show you how to move away from that now and obtain these so-called choline normal to choline abnormal ratios, and this in turn will improve our specificity in our neurodiagnosis. And then finally the impression, just summarize all the MR changes, perfusion, spectroscopy, and whether it's in keeping with tumor, non-tumor, and so on. Okay, so that's how we would report our perfusion and MRS. When we do MRS, I think regardless of what manufacturer you use, most of them are spitting out these numbers and these ratios now, so you can obtain this automatically from the softwares, and you can use that if you like. We've tended not to use that because, number one, I think we're able to either quantify the ratios by ourselves. So on the Semen scanner, you can see that if you want a choline to creatine ratio, you can put a line across here and see that the choline level is 75, the creatine level is 85, so the choline to creatine ratio would be 75 divided by 85.88. Now, if you're using some of the other scanners, say you spent $2 million buying a scanner that didn't give you the scale, I would go out and spend $1 buying a ruler. So then you would measure the height of the metabolite. So say here it's 7.5 centimeters divided by 8.5 centimeters. And again, that'll give you a ratio. These are the ratios that you want to calculate. Similarly for NAA, if it's NAA 160 divided by 85, that'll give you an NAA to creatine ratio. That's what we were doing in the past, and a lot of people are still doing that. But what we're trying to teach now is to measure the choline level in the abnormal side relative to the choline level in the normal side. So this will give you a choline abnormal to a choline normal ratio. So you can see here, this is a choline normal map. You can measure that height with a ruler if you like. And you then determine the choline level in the abnormal side, and then you can do a ratio of abnormal choline to normal choline. And I think in this way, we can increase our specificity much more. Okay, so let's look at a couple of non-tumoral cases. This is a patient that came to us with intractable seizures, had a MRI January 4th. A few weeks later, had a repeat MRI. You can see very diffuse cortical, subcortical changes on T2 and flare. Here's diffusion weighted imaging. And 2 or 3 weeks later, a lot of these changes were resolving. Anyone have a diagnosis for this abnormality? a little tricky. The last group came up with maybe a Press syndrome or some kind of encephalitis, yeah, herpes maybe. All right, a little tricky. This was a case that was very difficult for us as well, and we did MRS on it, and what we found on MRS was that there's decrease in NAA, there is some increase in glutamine-glutamate, there is some increase in the choline peak here, as well as a decrease in the myo-inositol. Okay, anyone have a diagnosis now? Okay, so if you were to see this spectrum next time, you will know that you will see this abnormality in the setting of hepatic encephalopathy. And this is a fairly specific metabolic spectrum, and the reason for the changes are that you see some neuronal damage from the encephalopathy causing the NAA decrease. There's probably some damage to neurons which elevates the GLX peaks because of the abnormal metabolism and abnormal osmolality. A lot of myo-inositol is excreted by the kidneys, so the myo-inositol is reduced. So this spectrum is, even though the MR looks very bizarre looking, the spectrum is fairly good for hepatic encephalopathy. You sometimes see this spectrum also in a uremic encephalopathy. And that patient incidentally had gallstones and was also an alcoholic and ended up with those findings. So if you were to compare that with Alzheimer's disease, that has almost completely the opposite findings in terms of the GLX and the myo-inositol. So remembering that in hepatic encephalopathy, the GLX is elevated. In Alzheimer's disease, the GLX peaks are reduced. Okay, and this is felt to be a neurotransmitter. So in Alzheimer's disease, a lot of the neurotransmitters are reduced. So the GLX is reduced. The myo-inositol and choline levels are elevated, and the myo-inositol is elevated probably because we think that there may be some more gliosis or astrocytosis in Alzheimer's. People have also correlated with the myo-inositol levels with the amyloid plaque load within Alzheimer's brains. And in one large study by Brian Ross and their group, they found that this spectrum of findings in Alzheimer's disease was 100% sensitive in 500 patients with postmortem correlation. So if you see a patient with Alzheimer's, these are fairly specific findings. Even they actually compared it with PET, and I think it had demonstrated higher sensitivity and specificity than PET imaging. In ALS, the findings are fairly similar. You'll see a decrease in NAA and an increase in choline and myo-inositol if you were to put a voxel within the precentral gyrus. And the other sign that I find kind of curious is on T2 weighted imaging and sometimes on flare imaging, you see this thin band of T2 hypointensity within the precentral gyrus. So look for that, and if you were to do MRS, again, look for the decrease in NAA and increase in choline and myo-inositol. In Canavan's disease, there is a deficiency or an absence of the enzyme that metabolizes NAA. So as a result of that, the NAA levels are very high. So this is an entity where MRS can be fairly specific and fairly useful. If you see very high NAA levels, there's very little else it can be but Canavan's disease. In the setting of some of the mitochondrial leukoencephalopathies, you will see lactate. So this is from the Hopkins group where they do very long echo time MRS, and the lactate peak is above the baseline. So you can see that there's elevation of the lactate. There's some decrease in NAA. Even within the CSF, you'll see some lactate elevation. You can see a lactate map here demonstrating increase in lactate throughout various regions of the brain. There's an entity called pyruvate dehydrogenase deficiency where alanine is seen elevated. As you've already seen earlier today, some meningiomas will demonstrate alanine increase. In this entity, there will also be some increase in alanine and some decrease in NAA. Typically with adrenal leukodystrophy, it involves the posterior white matter. I normally compare that with Alexander's disease, which has a frontal predisposition. In this patient, he has an atypical ALD where there's some frontal involvement as well. We did MRS on it, and we found that the choline was elevated from the demyelination, and there's some decrease in NAA, probably from the neuronal loss within adrenal leukodystrophy. We started to do some MRS within the cervical spine, and with the Bond scanners now, you can actually get fairly nice looking spectra, NAA, choline, and creatine from within the cervical spine. And what we're finding is that in spondylosis, where there's no abnormal cord signal, so a normal appearing spinal cord, we're seeing some diminution in NAA and some elevation in choline. Again, we think that there's maybe some early demyelination occurring, maybe some early neuronal loss from spondylitic patients. Okay, so I'm going to shift and change gears for the last 20, 30, 25 minutes or so and talk about the indications in terms of differentiating tumor from non-tumor. Okay, so again, you've learned that this can be either normal in a neonate or abnormal, but it can be abnormal in a whole bunch of different disorders. So it can be low-grade tumor, it can be meningioma, recurrent tumor, ischemia, TDL, metastasis. So if you would look at just a single spectrum in itself, you would probably be misled and felt that MRS is pretty useless. Useful nightmare maybe. So what I'm going to show you is how you can increase your specificity and try and get away with using MRS and improve your reports and increase your confidence really in making a diagnosis. So if you were to just look at a single spectrum, I think that's very foolish. Try not to do that, but look at the contralateral side and compare one side from the other. So we're going to look at all of these objectives. This is our job as a radiologist when we're trying to image a tumor to answer all of these questions. So the first thing is to try and determine whether it's tumor or non-tumor. This case we already saw this morning. Everyone happy with this case? Understand it? Understand how MRS and perfusion can be useful? Yes? Very good. Okay. So the take-home message is that metabolites are decreased in a setting of a stroke, and you want to normalize the scale to do so. And if you don't have a scale, then look at a spectral map, compare side to side. Choline and all the other metabolites are reduced markedly in the stroke compared with normal. So no question, this is a stroke. When you look at the perfusion, the 3 ROIs within the perfusion are demonstrating delay in transit time, as well as an increase in blood volume, but more importantly, delay in transit time conforming to the left MCA territory, all in keeping with an MCA stroke on the left side. Now, here's a comparative case which was sent to us, and this patient actually had the full workup, CT, MR, MRS, and perfusion at a very reputable hospital in the tri-state area. And the CT demonstrated this lesion in the left insula. There is some gyroform thickening and some loss of the gray-white. There is some sulcal swelling following GAD. There is some patchy enhancement. Some of it may be gyroform. Diffusion, maybe some patchy areas of diffusion restriction. Who thinks this is a stroke? Put your hand up. Everyone has to put their hand up once. Who thinks this could be a tumor? Put your hand up. Okay, so again in the audience, 50-50. Very good. So this was read as a left insular infarct with perfusion and spectroscopy and was sent to us for further workup and for surgery. So it was sent to Pat Kelly, our chairman of neurosurgery, to try and take out this lesion or determine whether it's stroke or tumor. So we then took the patient and did MRS on it and found this. So if you looked at the choline map, very, very marked elevation in choline. Looked at the individual spectrum. Here's a normal spectrum from a normal side, NAA, creatine, choline, normal looking spectrum. Here's the abnormal spectrum taken from the left insula. You can see that the choline is elevated, very markedly actually. You can even see that on the spectral map when you compare from side to side. And then when you normalize it, so here's firstly the abnormal spectrum, and you look at the scale, here's 0.4, so roughly about 0.6 for the abnormal choline. Now if we just look at a normal spectrum not to scale, again doesn't show a lot of difference, but if you were to scale them properly and scale it so the scale in the normal side is the same as the abnormal side, here at 0.4, you can see that in fact the choline in the abnormal side is markedly elevated compared with the normal side. So based just on the MRS, I was fairly certain that this was a high-grade glioma in the left insula. So we then looked at the perfusion, voxel within the normal brain, two ROIs within the left insula, demonstrating marked increase in blood volume, certainly much more than a stroke in the left insula. So I was pretty certain that this was a high-grade anaplastic, or certainly a high-grade glioma. So the patient was on a stretcher, going to the OR for resection of this left insula. So remembering that the prior report was and some of you felt that this could have been a left insular stroke. So we get a phone call as we're taking the patient on the stretcher to the OR, and the doctor who read the scans from this other place said, please don't take the patient to the OR. You're operating on a stroke. You're going to cause a hemorrhage. You're going to kill the patient. So Dr. Kelly called me and said, look, we're getting calls from Mount Sinai not to operate on this patient. Are you absolutely sure that you're dealing with a tumor? So are we absolutely sure we're dealing with a tumor now that you've seen the MRS and the perfusion? Yes? Yes, right? So I said, Dr. Kelly, I'm absolutely sure we're dealing with a tumor. In fact, I'm so sure we're dealing with a tumor, I'm going to bet my house on it. And I could do that at the time because I didn't have a house. So I said, go ahead. So they opened the brain, did a craniotomy, did a frozen section, and found that this was an anaplastic astrocytoma. Then resected the tumor, and the path obviously came back as a high-grade tumor. So now you can see, from the cases that we've shown you, how specific and how, confident you can be when you're looking at the MRS and the perfusion. Here's another case. Again, the same question, tumor, stroke versus TDL, something else. Okay, so who thinks this could be a tumor? Hand up. Certainly looks like a very high-grade tumor. You may have seen this already. Dr. Grossman may have shown it this morning on his talk. Who thinks this could be a stroke? If you had an azygous A1 segment or azygous A1 and A2, potentially that could split and supply both frontal regions. So, you could potentially have a stroke as a result of that. Who thinks it could be something else, non-stroke? Okay, so at the time, we weren't that sure, and you look at the sagittal image, there is some mass effect and expansion of the callosum there. So the surgeons also weren't very confident that the patient had a frontal lobectomy, and this turned out to be a tumor-factor demyelinating lesion. And from a bunch of cases, we learned that, again, when you normalize the choline, it's really not as high as in a tumor. And then when you look at the NA levels, NA is probably not as reduced as in a very high-grade tumor. And more importantly, when you look at the perfusion map, if you see these little venules, and I think a few people have already shown you that today, if you see these little venules running through the lesion, you can be pretty certain that you're dealing with a TDL. We've already seen that a meningioma, you'll see this alanine peak at 1.48 ppm, so I don't want to go into that. In extraaxial tumors, in a pituitary adenoma, there are no metabolites. In a craniopharyngioma, there's lipid and lactate, so you can use that. Optic glioma, typically because it's of glial origin, there'll be lots of choline. In PNETs, the primitive cells from a medulloblastoma or a primitive PNET will demonstrate this metabolite. It's probably a glycine or a taurine peak seen at 3.66 ppm. So if you see that, you can then differentiate a PNET or a medulloblastoma from an ependymomas in the posterior fossa. So that can be useful. In a pyogenic abscess, and this was work done out of India from Rakesh Gupta's group, you'll see a whole bunch of amino acids which are produced by bacteria. So these bacteria, they break down these amino acids, and you end up with metabolites like succinate at 2.4 ppm, leucine, isoleucine, valine at 0.9 to 1 ppm, acetate at 1.9 ppm. So what they did very cleverly in this paper was they obtained in vivo MRS and obtained all of these metabolites, these amino acids, and then they took out sucked out the pus and put the test tube into a spectrometer and actually did ex vivo in vitro MRS and found very good correlation between the in vitro MRS and the in vivo MRS. And so if you were to see a very bizarre looking spectrum, you're probably dealing with a pyogenic abscess. In the setting of PML with HIV, you'll see decrease in NAA from the neuronal loss. You may see some lipid and lactate. You'll see elevation of myoinositol and elevation in choline. If you have a lesion that is lymphomatous, so lymphoma is a very cellular tumor, the cells are packed very closely together. So typically the choline, as a result of that, is very, very high. There'll be some decrease in NAA. Tuberculous lesions, because remember on the capsule of the tuberculous bacteria or the tuberculous lesion, there is a lot of lipid and lactate, so you see typically lipid and lactate with TB. We've already discussed earlier today some of the limitations on why you would do MRS and perfusion for determining glioma grade, partly because path is really has some limitations, and I think you've already seen some of this data where we're differentiating low-grade from high-grade enhancing lesions and non-enhancing lesions in this study where we looked at 160 patients, and we feel that both perfusion and MRS are very good at differentiating low-grade and high-grade gliomas, but we think that perfusion is probably a better test than MRS, and even when you combine MRS and perfusion, we always would tend to look at the perfusion rather than the choline ratios because we don't think that's really that specific. And it's because I think in the very high-grade glial tumors in the GBM, sometimes the choline is pretty low because of the necrosis, and sometimes in the very low-grade lesions, because it's very cellular, the choline can be very high. So I think in terms of grading tumors, MRS is certainly not as good, and if you look at the receiver operating curves, not as good as perfusion. So what about localizing for biopsy? We've certainly used perfusion for that. Some people are using MRS, and you look at a choline map where we know that the extent of a tumor is certainly beyond the enhancing component, often even beyond the area of T2 signal abnormality. And this can be helpful for the surgeon to plan whether to resect maximally or to resect more aggressively, or if there's tumor beyond the hemisphere, they may elect not to do anything. And this is really demonstrating its utility in helping the surgeons plan their craniotomy. With some of the software now, you can interpolate your data set and obtain very high resolution spectral maps. So you can see that from an 8x8 matrix, you can actually make the voxels much smaller, and these are 5 millimeter voxel sizes now, and get very high resolution MRS. Defining the peritumoral region, we've been through already, and just to emphasize again that the peritumoral MRS and perfusion is very different with a infiltrating high-grade tumor versus a metastasis. If you look at the peritumoral MRS, choline is typically very high in the peritumoral area. Compare that with the breast metastasis, where you can see that if you look at the peritumoral areas, the spectra are pretty normal looking as opposed to an intra-tumoral spectra where the choline is elevated. So in that way, we can easily separate metastasis and tumor. What about in this very, very difficult setting after a tumor has been treated? Are we dealing with therapy-related necrosis or recurrent tumoral disease? Probably 95% of the time, it's this. And that's because when you think about it, the only reason why tumors having radiation or being scanned repeatedly is because there is a combination of tumor disease as well as treatment changes. And certainly within the first 6 months, that's the case in almost all cases that you will see, 100% of cases. Beyond that, very often you will see both. So what do you see in that setting? Well, here's a case that we had initially where it was a GBM, had high dose radiation therapy, and we did MRS on it. This was early on in our experience when we saw really no metabolites. And we learned from that when you see no metabolites, you're dealing with radiation necrosis, and you can confirm that. And I think that perfusion, again, is a very nice test, not only to confirm, but certainly in the difficult MRS cases to tell you that you're dealing with non-viable tissue, and this is radiation necrosis. Just a caveat to that, in the first 6 months after radiation, this is work that's come out of the UCSF group, you can see that in the first 6 months after radiation, this is a little dose dependent as well. The choline to NAA ratio will progressively increase. The creatine to NAA ratio will also change, and the choline to creatine ratio will alter as well. So keep that in mind, that because of the demyelination that's occurring in normal brain in the first 6 months after radiation, there will be some increase in these metabolites. But otherwise, in the clear-cut settings like this case, which Ed had shown earlier, if there's increased perfusion, very marked increased choline, compare choline from one side to the next. If the choline is very elevated, then you're dealing with radiation necrosis. As I said, maybe 90%, maybe even more of the time, you deal with a spectrum that looks like that. So what do you do in that setting where there is almost always a combination of tumor as well as necrosis? Well, we tend to bring the patient back and scan the patient again. If the choline is progressively increasing, we're dealing with recurrent tumor. If the choline is decreasing, but we're seeing some lipid and lactate, then we're probably dealing with radiation necrosis. Well, it's certainly heading towards a necrotic, non-viable tissue kind of phase. Obviously, if there's no metabolites and you're heading in that direction, then you're dealing with non-viable tissue. I want to finish with two algorithms, and this is, I think, something that will become important, and this I think will be published by Dr. Mellon from Penn. And this algorithm, I like it because it based it on some of the work that we published from here. And I think it's clinically very useful. So the way it works is that if you have a ring-enhancing lesion in the brain, first thing to do is to look at the DWI, look and see whether it's positive or negative. If it's positive and the blood volume is low, then you're dealing with either an abscess or a lymphoma lesion. And this algorithm is on your CD, so I don't have to copy it down. But if you have these two differentials, an abscess or a lymphoma, if there are areas of central necrosis, then you're dealing with an abscess. And you can go ahead and confirm that with MRS now. If you find that there's no central necrosis, and you're probably dealing with lymphoma. And then on the other end of the algorithm, if you find that the lesion is not diffusion positive, so in other words, there's no diffusion restriction, then you're left with 4 differentials: a TDL, tumor factor demyelinating lesion, delayed radiation necrosis, glioma, or metastasis. In that setting, if the blood volume is very low, you're probably dealing with a TDL or radiation necrosis, and again, you can confirm that with MRS. If there is high perfusion, high cerebral blood volume, then you're left with 2 entities, either metastatic disease or glioma, high grade. If you then look at the peritumoral MRS and CBV, if this is elevated, then you're dealing with a high-grade glioma. So in that fashion, you can then triage and determine which is the more likely differential. If you have a non-enhancing lesion, then if it's, first if you look at the mean transit time in CBF, as we talked about this morning, then this will tell you you're dealing with an infarct. If the MRS is showing that the choline to creatine is not that high, about 1.6 maybe, you're dealing with probably an encephalitis, and you can confirm that by looking at the blood volume. If the MRS is showing high myoinositol level, and a few different people have described this now, you're dealing with either cortical dysplasia or a low-grade glial neuronal type tumor. If the MRS is showing a very high choline to creatine, then look at the, then you're dealing with the primary tumor, and if the blood volume is low, probably a low-grade glioma. If the blood volume is very high, then you're dealing with a high-grade tumor. So I think in this way you can separate both ring-enhancing and non-enhancing lesions. And lastly, these are the books that I have tended to read and tended to recommend, and they're all available on Amazon.com. This is a book by Nuha Salibi and Mark Brown, who put together a nice little handbook on MR spectroscopy. A lot of nice cases in this book by Elsie Danielson and Brian Ross. And then recently from some people at NYU, a book on some of the neurodegenerative and metabolic diseases with the MRS. So if you want to read some more, you can look these texts up as well. Okay, thanks for your attention, and thanks for coming.